Dr. Paul Kurdyak is a psychiatrist and scientist at the Center for Addiction and Mental Health in Toronto and a senior scientist and lead of the Mental Health and Addictions Research Program at ICES. And he joins us in studio. How are you, sir?
Great, thanks for having me.
All right, your study measured the incidence of psychotic disorders across different groups in Ontario. When you stepped back and looked at the findings, what surprised you the most?
Well, I think the first thing that surprised me, and I should say at the beginning that I was a co-author on this study. It was led by a colleague of mine at the University of Ottawa, Dr. Daniel Myron, did a great job on this project. When we looked at the findings, there are a couple things that struck out. One is that the incidence, which means the rate of newly diagnosed individuals, is increasing over time. Mm-hmm. It is happening in younger individuals over time. And then the third piece is the way that the diagnoses are breaking out. So there are different types of diagnoses that are part of what we call psychotic disorders. And that's a bit of a nuanced aspect of the study, but that was a third piece that was kind of interesting to us.
All right, well, let's pick up on that. When you say psychotic disorders, what do we mean? We have schizophrenia in one realm, an umbrella term, perhaps, and then we have schizophrenia, and then we have psychosis. Help us understand sort of the terms there.
Yeah, so there's schizophrenia and schizoaffective disorders, and for people to be diagnosed with those conditions, they need to meet certain criteria, and that the incident rate for those diagnoses have increased a little bit, but not that much. The one that's increased more so is called psychosis not otherwise specified, and this is a diagnosis that clinicians like myself use when somebody is clearly presenting with prominent psychotic symptoms, like a deviation from reality.
Talking hallucinations,
delusions, exactly. And but there are other issues that prevent us from saying it is clearly schizophrenia and schizoaffective disorders. So we know that the person's psychotic, but there could be other factors that may ultimately be contributing to it, like it could be related to substance use, it could be related to medical conditions, et cetera, et cetera. So it's kind of like a hedge diagnosis.
Okay.
It is definitely a psychotic disorder, and most individuals with this diagnosis do over time evolve to developing a diagnosis of schizophrenia. It's just it suggests a level of uncertainty that is truly schizophrenia at the time of first diagnosis.
Okay. I don't want to simplify it, but fair to say, like you mentioned, the specific set of symptoms, one of them is it's chronic with schizophrenia. Mm-hmm. That is long-term. That's about usually 6 months or more?
Correct.
Okay. All right. I want to look at a graph from this study. This graph shows the incidence rate ratios for schizophrenia spectrum disorder, which is in the dark blue color.
Yep.
Psychosis not otherwise specified in green, and psychotic disorders, which include both schizophrenia and psychosis, in black. Now, for each cohort studied, this is comparing to the 1975-1979 cohort. For psychotic disorders, the black line, there is a gradual increase in the rate of diagnosis starting with those born in the 1985-89 cohort. When researchers separated the data, it showed that the rate of schizophrenia goes up slightly, but then starts to go down, but the rate of psychosis increases kind of like a ski hill. What is this telling us?
Yes, so if we return to the difference between psychosis not otherwise specified and something that is like truly a schizophrenia spectrum disorder, it is the marked increase in the sort of the slightly uncertain category, the psychosis not otherwise specified, which means that at the time of first diagnosis, there is less certainty that this is truly schizophrenia, which means that there's complexities in the diagnosis over time that is increasing the most.
A lot of headlines in terms of what is causing it. This study was not looking at what was causing this, but help us understand what are some links that have been sort of made.
Yeah, so I think the first important point is that this study was very well designed to characterize changes in rates over time. There's nothing about this particular study that helps us understand why we're observing what we're observing. So when I think about the links, it's really like extrapolating to evidence beyond this study. But I would say what we are observing generally amongst young people, and these are 16 to 35-year-old individuals typically, what we're observing amongst young people is they are far less stigmatized than previous generations and much more inclined to seek help. So that may partly explain why we're seeing more and younger. The other factor is that over time, there has been more robust implementation of early psychosis intervention programs provincially.
Okay.
So anytime you put more services into a province, there's a tendency to pull in more cases. And then the third piece that actually is the cause for concern is the fact that the rise in the less certain diagnosis, the not otherwise specified, is occurring dramatically at a time of cannabis legalization. And what comes with cannabis legalization is that young people are exposed with high potency cannabis, which evidence outside of this study suggests does pose a serious risk for the onset of psychosis.
What does cannabis, high potency or not, these are young brains that we're talking about. We're talking, when they're still developing up until about the age of 25. But what does it do to the brain?
Yeah, so it's not entirely clear, but there does seem to there's an aggregation of evidence that suggests that there's something about the THC chemical in cannabis that binds with certain receptors in the brain that causes a biological inclination to become psychotic. So the way I think about it, and there are people who are more better experts than me on this, is I think if you are vulnerable to developing a psychotic disorder, exposure to high potency cannabis may increase your likelihood to develop a psychotic disorder.
Okay. Is there a difference between men and women?
There's been a baseline difference in men and women in the onset of schizophrenia. So men develop psychosis at a younger age. They tend to be more disabled as a result of the condition. The ratio of men to women is a little higher in men. And of course, as it relates to the cannabis risk factor, and actually to the service utilization, young men are notoriously difficult to engage in healthcare, and they are much more likely to consume substances than women.
We talked about legalization, of course, 2018. Looking at this data, and of course this is just the beginning here, was that the right call?
Yeah, so it's an important question. The policy is inherently a compromise, and I think that the legalization issue in 2018 responded to a couple of important issues. One is that if you walk around Toronto, there's clearly a public interest in having ready access to marijuana recreationally. That is just what people want, and so policy follows what people want typically. I also think, and this is a really important piece, is that when cannabis was illegal, the consequences of it being illegal, incarceration for possession, did not happen equitably, and that we knew that more marginalized individuals were more likely to be incarcerated and have all the negative consequences of having a criminal record, et cetera, as a result of that. So that was a very good, legitimate reason to enact the policy. But now, as more evidence emerges, this is what we want to be able to do, right? Monitor unintended consequences of policy. So now what do we do? And to me, tobacco is probably a better example than alcohol. Tobacco is a legal substance, but it's pretty highly regulated and highly taxed. So, I think there are policy solutions to find that compromise or balance between, maintaining the benefits for which the policy was first enacted, at the same time, address some of the risks that we're learning about.
All right. Receiving this kind of diagnosis can be frightening for many. Could you explain how this diagnosis is challenging for the individual or for those who are in their lives as well?
This is, my clinical work is in the CAMH emergency department, and this is one of those ones where you really feel for the individual. So how it manifests, it is often a slowly evolving sort of deviation from reality, and also often a slowly evolving social withdrawal. So a young man in high school, like totally social, engaged in everything, starts to withdraw from stuff, then starts like avoiding school, reluctant to avoid school. Family starts noticing that he might be sort of talking to himself, laughing inappropriately at times. So that's kind of how it manifests. And it's incredibly important that individuals have access to care early, because we know that the longer an individual goes untreated, the worse the prognosis is. Like if we can get people into care early, we can really change the trajectory of a young person's life.
I think I know the answer to this, but are there enough supports in place for those seeking treatment?
So I would say that throughout our province, we know that we don't have enough services for individuals struggling with mental illnesses generally. In this case, we do have, in comparison to other areas of our mental health system, we do have a robust system of early psychosis intervention programs that currently exist. But evidence that has come out of my research team suggests that even though this provincial network exists, not everybody with the disorder can or does access them. And some of that has to do with inadequacy of resources. Some of it has to do with awareness. And so, for example, if you're diagnosed by a psychiatrist or diagnosed in a hospital setting, you're much more likely to be referred to one of these programs, than if you were managed in primary care. And that's probably just an awareness situation. That's a big problem, because what we know about the consequences, in addition to longer periods of no treatment, this is a deadly illness. That people who are diagnosed in a hospital, these are 16 to 35-year-olds, 1 in 25 die within 5 years. If you're diagnosed in an outpatient setting, 1 in 40. Nobody should be dying between the ages of 16 and 35.
And how do they die?
The most common cause is suicide.
Okay.
Yeah, the suicide rate is incredibly high, and it just makes sense, because these are young people who have a sense of who they are and what they're going to be doing in their life, and their whole identity gets rocked by this diagnosis.
All right, Doctor, we're gonna have to leave it there, but I really appreciate your insights. Thank you for this, and of course, with this, there will be more things to come out of this in terms of research and studies and policy, so we look forward to that, and thank you so much.
Thanks very much for having me.